Good morning, my dear students. So today we will be starting off about another topic of cardiovascular system which was left behind, and that is your arrhythmias, drug used in arrhythmias. Now, as a student you should remember these drugs, antiarrhythmic drugs, are itself pro-arrhythmogenic drugs. So these are the drugs which are commonly used by only the specialist. General practitioners do not use this drug because their therapeutic margin of safety is very narrow. Now, as you know, in contrast to skeletal muscles, which contracts only when it receives a stimulus, otherwise it cannot, skeletal muscle cannot contract. But in case of heart, as they contain specialized cells that exhibit automaticity, that is, heart muscle fiber has got the automaticity. They intrinsically generate rhythmic action potential in the absence of external stimuli. Now, these pacemaker cells differ from other myocardial cells in showing a slow spontaneous depolarization during diastole caused by an inward positive current carried by sodium and calcium ions. So, what happens that if you could remember the physiology of action potential of heart muscle, each and every heart muscle has got the capacity to generate their own impulse, but normally they do not generate any impulse because highest type of impulse is formed in the SA node. So according to the SA node rhythm, heart contracts. That means this depolarization fastest in SA node and it decreases throughout the normal conduction pathway through the AV node to the bundle of His and Purkinje system. Now, this is the normal things, but sometimes the ventricular muscle fiber, due to some injury or ischemia, they may generate their own impulse. In that case, they are called as ectopic pacemakers. Now, arrhythmias are caused by abnormalities in impulse formation, or there may be defect in the conduction in the myocardium. That may lead to the development of abnormalities of the heart rate, which are called arrhythmias. These arrhythmias are classified according to the site of origin of the abnormality, that we call it atrial flutter or atrial fibrillation done when the generation of impulse at the atria. Junctional, there is AV nodal, maybe ventricular. So according to the site of origin, they are called either atrial or junctional or ventricular. Now, according to rate, whether the rate is increased or decreased, if the rate is increased, tachycardia, or the rate is decreased, we call it bradycardia. Now, what are the commonest type of tachyarrhythmias? Atrial fibrillation, where the heart rate is increased but completely irregular. Supraventricular tachycardia, heartbeats are rapid but regular. Ectopic beats, the ventricular as well as supraventricular. The ectopic beats may be generated at the level of ventricle or at the supraventricular level. They include ventricular tachycardia, ventricular fibrillation. Now, ventricular tachyarrhythmias are less common but much more serious. Now, coming to the bradyarrhythmias. Now, bradyarrhythmias includes various kinds of heart block, example at AV node or SA node, or complete cessation of electrical activity. We call it asystole. Now, heart block results from fibrosis or ischemic damage of the conducting system, most commonly AV node. In complete heart block, atria and ventricle beat independently of one another and the ventricle beating at a slow rate. Now, sporadic complete failure of AV conduction causes sudden periods of unconsciousness and is treated by implanting artificial pacemaker. Now, coming to the classifications of now before classification we should know how these now, as I have said, the cardiac arrhythmias may be due to abnormalities of impulse generation, and this may be either enhanced automaticity of the SA node, abnormal automaticity and triggered activity. Abnormalities of impulse contraction or re-entry type of arrhythmias is heterogeneity, slow conduction, unidirectional block, etc. Now, abnormality in the impulse generation. After normal automaticity, after normal automaticity, that is enhanced automaticity occurs in SA node, AV node and Purkinje fiber, which normally display spontaneous diastolic depolarization. Now, fibers which normally display spontaneous diastolic depolarization. Now, it may be due to beta adrenergic stimulation, it may be due to hypokalemia and mechanical stretch of cardiac muscle cell, increase phase 4 slope and accelerate pacemaker rate by decreasing the phase 4 slope. Now, abnormal automaticity, what does it mean? That is, this is not normal automaticity, it is abnormal automaticity. That is after depolarization or the depolarization that interact at phase 3 or phase 4 and occur due to excess intracellular calcium ion accumulation, digitalis toxicity, catecholamine sensitization and myocardial ischemia. Now, this is called early after depolarization, and delayed after depolarization. Delayed after depolarization. This abnormality, this abnormal automaticity is due to abnormal depolarization triggered by a normal preceding normal depolarization and usually occurs due to drug toxicity, quinidine, digoxin, and in usually inherited ion channel abnormalities, namely congenital long Q2 interval syndrome. This is the abnormality of impulse generation. Now, abnormalities of impulse conduction or re-entry phenomena. Now, re-entry can occur when impulse propagation occurs through more than one pathway between 2 points in the heart. Three most important criteria required for re-entry are heterogeneity of refractoriness or heterogeneity of electrophysical properties in the two pathways of the conduction of impulse in two different directions. One pathway must conduct slowly enough such that excitability can be regained in other pathway before depolarization wave can make a complete cycle through the circuit. An unidirectional block. You just see this. Normally what happens? A impulse when it comes to the ventricular muscle fiber, it bifurcates into two, right sided and left sided. Now if there is any injury or refractory tissue lies in between the one pathway, the impulse is blocked in one direction. But where there is no injury or increased refractoriness, then this impulse goes and it will again come in this way, and ultimately there is a circuit phenomena. Every time it comes and it causes contraction of the ventricle. That is, impulse travels in the retrograde direction and re-enters the conduction pathway, causing an extra or irregular heartbeat. This is called your unidirectional block, and this is the most common cause of arrhythmia clinically. Now, Wolff-Parkinson-White syndrome. What is it? Now, impulse from AC node reaches the ventricle via the AV node and accessory pathway. Electrophysiological properties of AV node and accessory pathway are different. Impulse conduction through the accessory pathway is faster where compared to those according to the AV node. In a normal circuit, the impulse in the Purkinje fibers of branches into the direction and excites the ventricular muscles. In case an area of unidirectional block develops in one of the branches, preventing interrogate impulse propagation at the site of the block, the retrograde impulse may be propagated through the site of this block. This August, if the impulse find excitable tissue, that is refractive period shorter than the conduction time, this impulse will then re-excite the tissue it had previously passed through, and re-entry part is established and the process repeat in resulting arrhythmia. Now, what is Wolff-Parkinson-White? There is a accessory pathway from the atria to the directly to the ventricle. So it is coming again, there is a formation of circuit phenomena, and there is generation of arrhythmia. Now, anti-arrhythmic drugs are classified by Vaughan-Williams. Although there are some limitation of this classification, but this classification is accepted by the world. Now, according to the Vaughan-Williams classification, these are classified into class 1. These are all sodium channel blocker. Now, if you could remember from your physiology knowledge, if there is action potential of the heart is drawn, then you will find this type of this is phase 4, this is 0 phase, this is 1 phase, and this is 2 phase, and this is 3 phase. 0 phase means due to stimulation there is opening of the sodium channel. So the drug which are blocking the sodium channel, so automatically their depolarization rate, so depolarization amplitude will be less. Now during phase 1 there is opening of the potassium channel and potassium is coming out. This is called, so there is repolarization started. Again at plateau phase, that is phase 2, there is opening of the calcium channel. Then due to opening of the calcium channel there is formation of plateau, and again depolarization start, that is potassium is coming out, and ultimately is goes below the baseline, and again it comes to there is a slope formation which is called phase 4, and this phase 4 is due to leakage of the sodium and calcium inside the cell, and there is a developed formation of a slope. So according to this picture, you will find that class 1 drug, these are all sodium channel blockers. Now this class 1 drug again subdivided into 1A, 1B and 1C. Now 1A slows phase 04 depolarization, so they will block the sodium channel. They slow the phase 0 depolarization in ventricular muscle fibers. So automatically generation of impulse will be less, so they will be effective in the treatment of arrhythmia. So what are the examples? Quinidine, disopyramide and procainamide. 1B, the shortens phase 3 repolarization in this shorten the phase 3 repolarization in ventricular muscle fiber. These drugs, they are all sodium channel blocker, but at the same time they shorten the phase 4 repolarization in ventricular muscle fiber, and examples are lidocaine and mexiletine. 1C, markedly slows zero phase depolarization in market phase. Example propafenone and flecainide. Now class 2. Class 2 inhibit phase 4 depolarization. This phase 4 depolarization is inhibited by this group of drugs. These are all beta blockers, SA node and AB node. They all beta blockers like atenolol, metoprolol, ismolol. And class 3 calcium channel blocker. Sorry, no, potassium channel blocker. They prolong the phase. So as I have said, potassium is coming out. So these drugs block the potassium channel and prolongs the phase 4 repolarization in ventricular muscle fiber. So refractory period of this fiber is increased. So automatically the impulses will passes to the ventricle very slowly. Amiodarone, dronadarone, sotalol, dofetilide, ibutylide, these are the examples of class 3 drug. All are potassium channel blockers. Now class 4, calcium channel blockers. Inhibits action potential SA node and AB node. My dear student, you should remember in all other types, sodium channel is the first channel. But in case of SA node and AB node, predominant ion is calcium. So they are in SA node and AB node, you will not get this type of action potential. You will get this slow action potential due to entry of calcium. And now calcium channel blocker inhibit this entry of calcium in SA node, AB node, and used in the treatment of arrhythmia. Others which are not included in the Vaughan-Williams classification, but they are also used as antiarrhythmic drug. This is your adenosine, digoxin, magnesium sulfate, ranolazine. Now, I have included this uses of antiarrhythmic drugs and in which condition which drug is preferred. I have mentioned all these things here. Now, you will find sinus tachycardia. Sinus tachycardia means the generation of impulses at the AC node, but the rate is very high. In this type of ECG picture, you will find P wave is there. There is no absence of P wave. So, but the rate is very increased. This is called sinus tachycardia. Now, in sinus tachycardia, we commonly use class 2 and class 4 drugs. That is, calcium channel blocker and beta blockers are mainly preferred. And drug of choice is your propranolol in sinus tachycardia. Atrial fibrillation and flutter. where the generation of impulses are from the atria. We can use 1A drug, 1C drug, class 2 drugs, class 3 drugs, class 4 drugs and digitalis. But the drug of choice is esmolol, verapamil, decoxy. Now, as atrial fibrillation is and flutter is an emergency condition, so in that case we giving esmolol IV. Its half-life is very short. Esmolol is given IV and it will be corrected. Now, paroxysmal supraventricular tachycardia. Here we can use 1A, 1C, class 2, class 3 and adenosine. But the drug of choice is adenosine and esmolol. AV block. When heart block is there, and you can use atropine, and drug of choice is also atropine. Now, ventricular tachycardia 1, 2 and 3. Drug of choice lidocaine, amiodarone. Ventricular fibrillation classes 1, class 2 and magnesium, but the preferred drug is lidocaine and amiodarone. Now, let us consider. Now, this amiodarone is a broad spectrum anti-arrhythmic drug. It is very important, my dear student. So, you can expect short note amiodarone. Now, it is a multi-ion channel blocker and structural analog of thyroid hormone. Its mechanism action is it blocks the inactivated sodium channel, prevents the reactivation of sodium channel, it increases the calcium currents, it blocks the inward potassium currents, it has non-competitive at the it is non-competitive at the blocking at their blocking action. It is a potent inhibitor of abnormal automaticity. It prolongs the duration of action potential. It decreases the conduction velocity in all the areas of the heart. It prolongs the PR interval, QRS complex and QT interval. Now, extracardiac effect. Amiodarone accumulates in many body tissues like heart, lung, liver and skin. It is concentrated in the tears. It can cause pulmonary fibrosis, corneal microdeposits, peripheral neuropathy and photosensitivity reaction. And it can also cause hypothyroidism by preventing the conversion of T4 to T3. Regarding pharmacokinetics, absorbed orally and has a viability of 35 to 65%. It is converted to an active metabolite, desethylamidorone. Elimination half-life varies from 10 to 100 days to several weeks. It is a cumulative drug as the effect lasts for 1 to 3 months after discontinuation of the drug. Remember it. Rifampicin induces CYP3A enhances the metabolism of amiodarone with decreased serum levels. Now, what are the uses? It is a broad, as I have said, broad spectrum antiarrhythmic drug, ablates both atrial and ventricular arrhythmias, administered orally 200 to 800 milligram per day in divided doses for atrial fibrillation, paroxysmal supraventricular tachycardia, ventricular tachycardia. 150 to 300 milligram in 20 ml of normal saline given over a period of 10 minutes if arrhythmias persist. Supplemental doses of 150 milligram followed by 1 milligram per minute for 6 hours and later dose of 0.5 milligram per minute can be given. Now, as a prophylactic therapy, following open heart surgery, 1000 milligram IV infused over 24 hours. Adverse effects: bradycardia, heart block, hypotension. And other than this, it may cause hypothyroidism, there may be corneal deposits, etc., hepatotoxicity. Now, most important drug, most commonly used drug is lidocaine. It blocks both activated and inactivated sodium channels with rapidity. It undergoes extensive first-pass metabolism when given orally, hence it is given intravenously only. Half-life 1 to 2 hours. Dose 100 to 150 milligram as bolus over a period of 15 minutes, followed by 50 milligram every 8 minutes for 3 doses, and maintenance dose 1 to 4 milligram per minute. Uses and advantages. Uses: lidocaine is the most effective drug for a rapid control of rapid ventricular arrhythmia due to myocardial infarction, those that occur after cardioversion and those caused by inhalational general anesthetics. Adverse effects. It has the maximum safety profile among the anti-arrhythmic drug. In large repeated doses, it can cause acinodal conduction defects and acinodal standstill. The non-cardiac side effects include paresthesia, tremors, nausea, lightheadedness, hearing disturbances, and slurred speech. Now, adenosine, it is the drug of choice in paroxysmal supraventricular tachycardia. Important as short notes. Now, it is a naturally occurring nucleoside and is given intravenously as bolus dose to terminate re-entry supraventricular tachycardia. It has a very short half-life, 10 seconds only. Its mechanism of action involves activation of inward rectifier potassium currents and inhibition of calcium currents. This results in hyperpolarization and suppression of calcium-dependent action potential. It causes shortening of action potential duration. When given intravenously, it inhibits SA node conduction, and in SA node and increases AV node refractory period due to blockage of calcium currents. Intracellular cyclic AMP accumulation is decreased with reduced sympathetic activity. It is the drug of choice at present for prompt conversion of paroxysmal supraventricular tachycardia to sinus rhythm. Dose: bolus 6 to 12 milligram. Now, initially 6 milligram IV is given rapidly, followed by, if necessary, another 6 milligram can be infused. So, maximum 12 milligram. Maximum 12 milligram. Adverse effects: chest discomfort and shortness of breath, flushing, AV block resulting in asystole, hypertension, headache, and paresthesias. Thank you, my dear student. This is all about antiarrhythmic drug, but from this chapter, you should just remember the name of the antiarrhythmic drug, and you are to prepare amiodarone, lidocaine and adenosine. Follow my point? And in which condition, which drug is preferred? Right? In PSBT, we preferred adenosine. In just tachycardia, sinus tachycardia, we prefer propranolol. So ventricular tachycardia, we can use lidocaine and the amiodarone. So these are the things you just remember for your examination purpose. Thank you.